Hi, I'm Rania Ismail, Assistant Professor of Pediatrics and Neonatology at Shams University. In the next few minutes, we are going to talk about neonatal sepsis and necrotizing enterocolitis. By the end of this lecture, you should be able to explain why neonates are more susceptible to infections and identify the causative organisms of sepsis according to the timing of onset. Diagnose neonatal sepsis clinically and confirm the diagnosis with further investigations. Decide the need for prophylaxis and the proper choice of antibiotic therapy. Explain the pathogenesis of necrotizing enterocolitis. Diagnose necrotizing enterocolitis clinically and radiologically and propose management outlines. Neonatal bacterial sepsis has always been a major problem in neonatal intensive care units. It's associated with 10 to 40% mortality and significant morbidity. It's considered one of the infections that affects the newborn infant that include as well fungal infections, congenital infections, and perinatally acquired infections. Both systemic and local infections are common in the newborn period. Bacterial sepsis and meningitis continue to be major causes of morbidity and mortality in newborns, particularly in low birth weight infants. Neonatal survivors of sepsis can have severe neurological sequelae due to central nervous system infection as well as from secondary hypoxemia resulting from septic shock, persistent pulmonary hypertension, and severe parenchymal lung disease. There are three major routes of perinatal infection. The first is blood-borne transplacental infection of the fetus as CMV, rubella, and syphilis. The second is ascending infection with disruption of the barrier provided by the amniotic membranes, as in case of bacterial infections after 12 to 18 hours of ruptured membranes. The third is infection while passing through an infected birth canal or exposure to infected blood at delivery, as herpes simplex, hepatitis B, HIV, and bacterial infections. As we have mentioned, bacterial infections may be systemic or local. The most serious site of infection is the brain. That's why meningitis should be suspected early and managed vigorously. Pneumonia is a common presentation with sepsis. Other important and common sites of infection include urinary tract infection, umbilical cord causing ampulitis, and conjunctiva causing conjunctivitis. Preterm labor, premature rupture of membrane, maternal infections, intrauterine monitoring, intrapartum asphyxia, and intravenous catheter insertion are the predisposing factors to neonatal sepsis. This will be explained in the face-to-face session. Neonatal sepsis is classified according to the time of onset into early onset neonatal sepsis, which occurs in the first 72 hours of life, and late onset neonatal sepsis, which occurs after 72 hours of life. This will be explained in the face-to-face session. Identifying the common pathogen that causes sepsis in relation to the timing of the onset makes it more easy to choose the starting antibiotics. Early onset infection is more often caused by group B beta hemolytic streptococci, GBS, and gram-negative enteric pathogen, most commonly E. coli. Other organisms to consider are non-typable Haemophilus influenza, Enterococcus, Staphylococcus aureus, other streptococci, and Listeria monocytogenes. Late onset sepsis is caused by coagulase negative staphylococci, most common in infants with indwelling central venous lines, Staph aureus, GBS, Enterococci, and gram-negative organisms. Gram-negative organisms such as Klebsiella, Salmonella, and Serratia are more common in less developed countries. The incidence of early onset neonatal sepsis is 1 to 2% in 1,000 live births. The earlier the rupture of membrane, the more the infection rate. Infection rates are 5 times higher in preterm than in full-term infants. This relates to the more immature immunological systems of the preterm infants and to their prolonged periods of hospitalization, which increase risk of nosocomial acquired infectious diseases. The presentation of sepsis ranges from mild subtle symptoms to fulminant sepsis. Remember that early diagnosis and proper management of sepsis can decrease the incidence of serious morbidity. Clinical presentation varies according to time of onset. In early onset neonatal sepsis, respiratory distress due to pneumonia is the most common presenting sign. Other features include unexplained low Apgar scores without fetal distress, poor perfusion and hypotension, while late onset neonatal sepsis presents with more subtle manner as poor feeding, lethargy, hypotonia, temperature instability, altered perfusion, new or increased oxygen requirement, and apnea. Late onset neonatal sepsis is more often associated with meningitis or other localized infection. More will be explained in the face-to-face session. It's important not to think in neonatal sepsis like sepsis in children. In neonatal sepsis, fever may be absent. Even more, fever in healthy term neonate with no other signs of sepsis may commonly be due to environmental effects, with decreased fluid intake, a term called dehydration fever. It's so important to remember that any neonate who is not doing well must have sepsis workup. This will be explained in the face-to-face session. Laboratory evaluation of infant with suspected neonatal sepsis includes, initially, a complete blood count, ECBC, with differential. Total leukocytic count may be decreased, but sometimes it may increase. Neutrophil count will be low, with increase in ratio of immature to mature neutrophils. It is so common to have low platelet count. These changes in the CBC is only suggestive of neonatal sepsis. Other laboratory abnormalities can include elevated C-reactive protein, procalcitonin, hyper or hypoglycemia with no change in glucose administration and unexplained metabolic acidosis. For infants with strong clinical suspicion of sepsis or meningitis, a lumbar puncture for cerebrospinal fluid, cell count, protein, and glucose concentration, gram stain and culture should be performed.